Yes, thank you. Yeah. I've started.
That's great, thanks. So I just started this slide.
Perfect. I would like to welcome the now over 24 people that are on this call and counting up to this fourth Learning Health Systems Tech Forum, brought to you by the Learning Health community, a nonprofit organization that is dedicated to realizing learning health systems grounded in a set of core values we all came up with together as a real, true leaderful movement we're trying to build around this, and we've been working on it for a long time. The topic today is transforming clinical research networks into learning health systems. And next slide, please. And just to give a brief overview of what's going to be happening today, on a traditional format, I just have a few opening remarks about the community and how grateful we are to have you all here. Dr. AJ Chen, who's really the thought leader behind this particular initiative, is going to speak some more about just opening introductions. Then we'll hear from our two speakers, Dr. Yuri Quintana from Harvard and Carl Moor from Biogen. And we'll be hearing from our speakers, and we're really grateful for their participation and the work they're doing. And then we'll be closing with a Q&A. But in the meantime, one of the great things about the first three forums has been what goes on in the chat, including that John Birch, who posted a link, and Sarah, who said good morning. The stuff that goes on in the chat during this has been amazing because everyone participating just really has something to add. So please put your ideas, your thoughts, your questions into the chat. There's no such thing as a dumb question. Any question will lead to great discussion. So please just share what you're thinking. With that said, I want to again thank our organizing committee. You'll notice this is on a Stanford Zoom link, and we have Dr. Sophia Wang to thank for that. We're very grateful for the folks that have helped make it happen. AJ, of course, is leading it. We have Chuck Friedman and other advisors behind the scenes, and we're really grateful for the help and for everyone who makes it happen. We do have a job announcement coming from Dr. Ida Sim out of Berkeley. Fun fact, if you look at the New England Journal of Medicine letters to the editor from, I want to say mid or late September, you'll find a letter from me right next to a letter from Dr. Sim responding to an article. So anyway, we both got our letters to the editor published. But anyway, I wanted to post that job announcement about precise health, and that's really interesting. And I thank everyone who's helped really grow our audience for this and make it possible. We recently co-hosted one of these meetings with HIMSS, and HIMSS has been a big help. My colleagues at University of Michigan have helped behind the scenes. Stanford University, again, I mentioned that Dr. Sophia Wang she's been a tremendous help. Stanford's donating the Zoom support for this because the Zoom we have is not big enough to handle it. And we met the others, UCSF Health Pub, AMIA, and again, we're truly global with the EU's IDIH. So we are grateful for our global network of folks helping us. And at this point, I'm going to turn it over to AJ, who's going to introduce the speakers in more detail, facilitate everything, and just remind us about the connection to learning health systems, which many of us share a passion. And again, there's quite a number of people on this meeting who've been here since day one of this kind of group convening, which was very close to a decade ago when this all got started. So AJ, thank you for your leadership and facilitatorship, and I'm going to turn it over to you, and I'll be quiet.
All right, thank you. Thank you, Josh. So I'm AJ Chen, a co-chair for the Learning Health System Tech Forum. I'm based in Silicon Valley, specialized in learning health system. I enjoy designing a series of learning health system tech forums for our global community to discuss the learning health system technologies and practices. So let me first give a 1-minute introduction to the learning health systems, particularly for those people who are not familiar with this new emerging field. Basically, the learning health system vision was created by the National Academy of Medicine about 10 years ago. You can get several reports from their website to read about learning health system. This learning health system vision is designed to transform our healthcare systems to provide better care at lower cost. In my view, the learning health system has the following key characteristics at a system level. First, continuously improving care deliveries with continuous machine learning and research. Second, building rapid dissemination on AI-enabled digital platforms. Third, high efficiency from system-wide automation. Given the vision of learning health system, we organize a series of tech forums to help accelerate the implementation of learning health system. Our past forums had discussed the learning health system vision, the required infrastructure, as well as the interoperability. And the topics that we have been covering includes the following, basically cover the key aspect of the learning health system stack for example, at application level, AI tools, research networks, dissemination, health equity, and then the technology in terms of the knowledge, representation, and data standards and interoperabilities. Now, so today we are going to focus on the research networks and learning health system. And now let's hear the presentations from academic and industry experts. We're honored to have Dr. Yuri Quintana to present from Harvard to present the how to build collaborative online community of practices to improve healthcare. Yuri is the chief of clinical informatics at the Beth Israel Deaconess Medical Center, assistant professor of medicine at Harvard Medical School. Yuri, welcome, and the floor is yours. Let me stop sharing, and you can switch to your slides.
Thank you very much for the kind introduction and invitation to share work I've been doing with colleagues both here in Boston and around the world. So I will be sharing with you some of these initiatives. David Einstein, Dr. David Einstein here at Beth Israel is one of my collaborators here for Alicante, and he may join us later. He's in clinic right now, but I'm happy to be sharing with you this information. I'll be talking today about what are these, how do we define or how I view learning health networks, some implementations that I have done and some other colleagues have done, and what can we think about going forward, how we can expand these in a post-COVID-19 world. I'll be mentioning Alicante, which is a platform we developed here at Beth Israel that we've licensed to other academic centers. All other products are merely for educational references, and I have no conflicts of interest to disclose. So what are learning health systems? Well, a variety of different definitions have come up, and you saw those in the introduction. And one of the challenges is how do we take scientific evidence, translate them into practical implementation protocols that we can implement in clinics, evaluate them, and then scale them across a large population. And at each one of these stages requires communication and dissemination of knowledge, and also a feedback to the previous groups so that we can learn and improve from each of them. Connecting the dots from these different groups is actually really difficult. And one of the comments that was in one of those earlier Institute of Medicine, or now National Academies of Medicine reports, was that by 2020, the goal was to have 90% of clinical decisions that would be supported by accurate, timely, and up-to-date clinical information that reflects the best available evidence. And while that was a very lofty goal, I don't think we're anywhere near close to that 90%, which means that taking that evidence and putting it into practice and creating these active communications still requires a massive amount of work and design. So I'm delighted that there is this forum so we can learn from each other. There are forums where people can disseminate this knowledge. There are professional societies who typically have annual meetings. Some are having working groups as well, but those meetings typically are limited in scope. And to actually get down to the granularity of deploying these systems, you really need to be able to understand all of that is what is working and what isn't. And so one of the interesting things is if you look at some of these high-level reports, the very earliest reports of what is evidence-based medicine started from a group out of McMaster in Canada, David Sackett and Brian Haynes and others, who generated a methodology for generating evidence using systematic reviews and other computational methods and epidemiology methods. AMIA was a part of that. So Brian Haynes is a fellow of the American Medical Informatics Association. And so the methodology of creating high quality evidence has been around for a long time, but translating that into clinical care and implementing it with few errors is difficult, as has been reflected by several reports that show that medical errors is the third leading cause of death in the United States. And so the devil's in the detail of how you take that evidence and operationalize it. And so how do we go about building some of these learning healthcare systems? And my view is that you really need a broad set of collaborators that want to agree on some target goals, develop what is the best evidence, what are the actual clinical practice guidelines, and then how do you operationalize them in your hospital. You then have to train your staff, you have to implement it, you need to have quality improvement methods to be able to see whether you're actually implementing it, the protocol as was indicated, and share those best practices with other colleagues. And then ultimately see where the protocol needs to be improved and develop new methodologies. Each of these cycles could take 1 to 3 years. And the problem is that there's a lot of duplication of effort and people don't actually share their best practices. And as you train people, you have to actually get quite granular as to make sure you understand what it is that people need to be able to understand to be able to translate that into clinical practice. And so all of these things, education, training, data collection, quality metrics, and research informatics all need to be connected together. And so I started in Canada and got my initial informatics training from Brian Haynes and others in the informatics community. And I was fortunate to meet Charlie Safran, who is an informatics fellow as well from AMIA. And through them, I learned a lot of methodologies about how to scale. And in 2002, I went to St. Jude Children's Research Hospital, where they wanted to disseminate best evidence around the world and help groups customize that evidence to local practices that meet what are the realities in their particular countries. And so we built a platform for a learning healthcare community called Cure for Kids, where we not only shared the best education and evidence, but created collaborative spaces where people can meet online and develop operational, practical, implementable care guidelines that were based on evidence, but also based on the available resources in their country. And when we started with one group of 100 doctors in Central America, they standardized a common protocol for ALL and started sharing data on their outcomes and started training their staff. And that initial group showed a lot of success. They developed other communities for other types of childhood cancers, not only in Central America, but then that model was copied to groups in Asia, Africa, and ultimately also Europe and North America. And so over 400 online communities were formed. Each of them focused on a particular clinical care protocol, developing that evidence base, but also sharing implementation details of how they implement it in their local practices. And so these groups would meet online. Here you see some publications and also some of the meetings that happened between doctors in Morocco and different centers, collaborating with each other and with doctors in the United States and around the world, discussing difficult clinical cases. So over time, these groups were able to figure out how to optimally implement those and be able to start sharing data, not only in terms of outcomes, but more granular data. And so we built another data collection tool called Pond for Kids that allowed them to collect outcomes. And in Pond for Kids, you could actually enter the actual clinical trial outline and define what those protocols are. People could download those protocols in electronic form, collect aggregate data in their local countries using standardized collection formats, and then share those aggregate data with other centers. And so this became a group that not only shared knowledge and implementation practice, but outcomes data. And so over a 12-year period, survival rates for the most common types of childhood cancer in Central America went from about 20% to well over 50% over time. And so the success that happened there was also then replicated in other parts of the world. And this shows the power when people want to agree and share knowledge, share both how they've trained their staff, how they've operationalized that, and how they do outcomes knowledge. And so I'm a firm believer that the way in which we improve healthcare worldwide is creating these collaborative communities. And so what I focus on now is how to go about doing those networks. And one of the observations that I found is that sometimes the networks initially are too ambitious and want to collect too much data. And so you need to be very critical as to what data you're going to collect, what are your target goals, how do you do that analytics on that data, and how you share that knowledge among the groups. This is facilitated if people have common standards of encoding that data and standard vocabularies, and have ways to synchronize, aggregate, and anonymize or de-identify that data to create these collaborative. And here are some publications that talk to that. So I moved to Harvard and the Division of Clinical Informatics in 2014 with a desire to see how I could replicate this across different diseases in different parts of the world. And so we built a platform called Alicanto, which is an online platform that's a combination of both a learning management system, a group collaboration tool, as well as a clinical collaboration tool that allows you to have virtual tumor boards. And so this tool was developed in 2014, it launched in 2015, and has been used by a variety of different Harvard area hospitals. And it's named Alicanto. I'm originally from Chile. Alicanto is a mythical bird from Chile that helps miners come out of mines. It glows in the dark. And the way I think of healthcare is that we have a lot of silos, data's in silos, there are clinical groups that are in silos. And I think what we need to do is have systems and methodologies to connect people together and come out of their silos to collaborate. And so Alicanto encourages that. As I mentioned, it's a platform that can be configured in different ways, and it has both public information that can be accessed without registration, or you can have content that's only available through registration, and then you can create virtual communities of practice that meet online. This is an example of some of the communities that we've done with the Alicanto at our hospital. We're a network of 13 hospitals and 17 community affiliates. And so we've created a virtual network with over 800 members that have monthly meetings for virtual tumor boards. And then within the hospital, we have several virtual tumor boards that happen, and some of them meet weekly and some of them meet monthly. This is an example of the hematology where they are able to schedule meetings, share documents such as clinical practice guidelines, have asynchronous discussions, and then have a virtual consult area where they can go in there and upload difficult cases to discuss, cases that maybe fit outside of the clinical practice guideline and require a multidisciplinary set of experts. And so people can go in there, upload the details of the patient information in a secure area, and they can direct specific questions to different specialties. And so we've created a virtual community that is not only used for education, but also discussing those difficult cases and how to go about treating those patients. We've also built another platform for global prostate cancer This is in collaboration with Dr. Tim Rebeck at Dana-Farber and collaborators both in the United States and Europe and Africa. And we're building capacity in Africa for doing both research in prostate cancer and ultimately how to translate that research into clinical practice. And so we just got a NIH 5-year grant to expand this to help develop more training and expand this virtual community of practice. There's another Alicanto implementation at MIT, which is a global community of educators sharing best practices in learning and training as well. So that's a network of networks. And there are a variety of other global initiatives as well. Here you see some of them. For example, the James Anderson Center is particularly interesting because they have a lot of the things that I thought were also very important, the ability to both do education, integrate quality improvement, have data analytics, and create these integrated communities of practice. The RAF network started in Africa for Franco-speaking, French-speaking Africa, and it has a clinical network. I think the evolution of this follows a pattern where initially there are people who come together to share desire to share education, what's the latest evidence base. But I think where it gets interesting is when they want to collaborate and then implement those care guidelines in their own hospitals, and they're willing to help each other and share some of their implementation experience. And where they get the most benefit is when people actually want to discuss those clinical cases through virtual tumor boards and want to actually share data that can be used for quality improvement across centers. So while most centers have their own individual quality improvement programs, it's rare that you see multiple hospitals joining together. And I think to do this, you need a community of centers that a critical mass of people that want to share data, learn from each other, have common tools, and are inclusive and allow others to grow within that network. And where I think it doesn't work very well is where there are dominating groups that are focused more on the credit and they're more focused on their center being better than others, or a community that doesn't want to help each other. I think at the center of this has to be trust among different people to be able to share that data. So I think the future of this is really taking a systems level approach, thinking of not only how do we improve locally, but how do we reach out to other centers and create networks that we want to learn from each other. We need to take a systems-based approach. A lot of these things need to be multidisciplinary, so not just doctors and nurses, but social workers, and understand the patient journey through that system. And for that, we need to have a patient-centric model to be able to understand where it is. For example, a lot of the networks I was involved internationally, it wasn't until the social workers got involved that we started understanding the real reasons for patient abandonment and how to overcome that. I think we should involve in those networks both patients and family caregivers, and then learn how to tailor the education and the collaboration styles to different subgroups within that learning network. We need to build these tools such that they're accessible and integrate into our workflows. And I think the evaluations have to include a multifaceted approach, not only of clinical outcomes, but how we did education, the quality of communications, and some common metrics for quality improvement. So I think by taking a systems-based approach, I think we'll be able to do that. There's a body of work that we've been publishing on this area, and I look forward to learning from all of you and hoping that other people around the world continue to develop learning health systems. Thank you.
And Yuri, I just wanted to let you know I hopped on late. So if there's
great.
any med-on questions, I can chime in.
Okay, great. Thank you, David. So I want to thank Dr. David Einstein, who has been a real champion of Beth Israel's implementation of the virtual tumor boards. And his group is one of those that meets weekly. And David, maybe if you want to just share what your, in the next 2 or 3 minutes, what were your impressions and what were some of the reasons that your group has been so successful?
Sure. I don't know if I can say why we're successful, if we even are, but clearly at the beginning of COVID, we had to make a pretty dramatic shift from our standard of care tumor boards, which was everybody gathering in a conference room and submitting cases to one designated person who would assemble an Excel spreadsheet that then had to get updated multiple times and sent around an email list. It was not a very good system, but all of a sudden, COVID catalyzed a real shift, and so I think that pretty rapidly we were able to use Yuri's Alicanto platform to assemble a case list for each tumor board. We were able to customize it to tag different services like a radiology review or pathology review. And then lately we've been trying to translate that into also facilitating referrals around our network, not just assembling tumor board lists. But I would say in the last year and a half or so, we've really gone from being a group of people gathering in the conference room to actually having our satellite urologists and medical oncologists be able to participate and have a lot more standardized way of doing this that will also allow us to do various QI and research projects in regards to what it is that we're actually making decisions on.
Thank you, David. And I see a question about in the chat area that's from John Birch, and says, question, rare disease advocacy groups typically see their primary task as the creation of registries and then try to find researchers dedicated to their disease. Should it now be to create a learning health system? And I think so. I think there's a lot of efforts in healthcare that are one-offs, and then afterwards they try to link with each other. And I think by proactively at the beginning thinking of what is the long game that we want to do, who should be part of the network, and trying to build tools that from day one are meant to integrate and creating a community. I think by having an active community that is has a place where they can go, not only to do an individual project, but go across groups, then you'll be able to have a larger success. So to the extent that we can have disease-focused areas that include registries, but also dissemination of the latest evidence and clinical practice, I think creating that community allows you to then have higher synergies than if all of those groups continue to build separate platforms and don't have a place to actively engage with each other.
Great, thank you, Yuri. Let's save all the questions to the Q&A session.
Thank you very much,
Yuri. Thank you, David, as well, for sharing your experience. And let's move to the next speaker. Let me share my screen first. All right. Now let's move to the industry focus presentation from Dr. Carl Moor, the head of data science and analytics at Biogen Digital Health. He's going to present the network that he's building and using for the MS care. Let's see. Previously, Carl also held positions at the Harvard Medical School as well as UT MD Anderson Cancer Center. Carl, the floor is yours.
Great, thank you. Let me
start my screen.
Yeah. Just give me 1 minute. So thank you, AJ, and thank you for the invitation to present here. I assume everybody can see the screen now?
Yeah.
Okay, great. So I'm going to focus on a specific case study of a learning health system in MS called MS PAS, or Multiple Sclerosis Partners Advancing Technology and Health Solutions. And the emphasis here in this brief talk is on generating research quality real world data. So for those of you who may not be familiar with multiple sclerosis, it's a disease of the brain and spinal cord where the immune system attacks the myelin sheath around the nerves. And long term, so this is a disease that unfolds over decades, can lead to permanent physical and cognitive disabilities. And so the typical age of diagnosis for multiple sclerosis is the late 30s, early 40s, and about 3/4 of patients are women. And so it does unfold over a long period of time, especially with the current disease-modifying therapies. And so some of the challenges of real-world data in multiple sclerosis include the fact that, let's say, if you conduct a prospective research study, although you have quantitative and standardized assessments, they're very expensive and there's low participation rates. When you generate data out of clinical practice through routine care, let's say using claims or EMR as sources, most of the outcomes that are important in MS, like disease severity and progression, just don't exist. And because the disease takes so long to unfold, patients in those data sets where let's say they're present for less than 5 years on average, you just see too short of a window of time for that patient to really learn from them. And then chart reviews, where you go into the site and pull the data directly. The clinical assessments are not standardized across sites. And in general, you have the same issue about the patient level outcomes not being collected systematically. And so MS-PAS is a demonstration project. It's a collaboration between Biogen and 10 healthcare institutions in the US and Europe. So 7 of them are in the US and 3 are in Europe. It employs some innovative healthcare technology, which I'll show in just a couple of minutes, to capture standardized quantitative clinical quality of life and neuroperformance and imaging data during routine care. So the clinicians that participate in MS-PAS can use that themselves. So it's a true learning health system, but it's also at the same time generating research quality that can be used across the network for publications and so forth. So the defining feature of MS-PAS here is that, and Yuri alluded to this as a key feature of successful learning health systems, is that the sites all agreed to change their routine of care. So they all agree to employ this assessment process that I'll show in just a minute, so that their routine care is generating these data. And so the patients are consenting just to share their data, not to take the tests, which their doctors use and require, but just to share their data. And then the data are aggregated across all the sites via a third-party broker. I won't go into that for this presentation. It's actually a whole presentation on its own. But it's aggregated across the sites by a third party. Biogen has its own data use committee where people within Biogen can submit for data access, given research project topics. The data use committee approves those, but importantly, the sites have their own committee. So Biogen is a non-voting member that sits on that committee, but it's the sites themselves that decide what will be done with the data by the site investigators. And that allows them to maintain the right independence. So if they wanted, they could show that Biogen's disease-modifying therapies are inferior to others. There's nothing Biogen can or will do. So I think it raises the quality, the bar on the work that they publish themselves. So these are the 10 sites, 7 in the US, as I said, 2 in Spain and 1 in, or 2 in Germany and 1 in Spain. And the selection criteria were very broad, that patients had to have at least 500, or the sites had to have at least 500 patients that they were treating in MS. They had to have a Siemens 3T scanner for MRIs, and this was a requirement to allow us to standardize the image capture and generate automatically quantitative measures, which I'll show in a minute. And then this willingness to standardize their procedures within their own clinic. So really change how MS patients were treated. And we have close to 18,000 unique patients, and I'll show some of the data. So there's 3 domains that are challenging and that MS PAS address. So the clinical data. So as I mentioned before, this is typically isn't standardized, but here within MS PAS, it is standardized using a device called the MSPT, or the MS Performance Test. The radiologic data, which are often very variable across sites using different scanners, different sequences, and so forth, are all standardized across the 10 sites. And then we also capture biological samples, blood, serum, and so forth from the patients. This is a volunteer aspect, so this is a sub-study, what we call, where the patients enroll in that separately. So this is what the MSPT device looks like. It's an iPad, and this is the home screen that the patients see when they're given the iPad by their the people at the clinic when they check in. The top left tile here is My Health, and this is the area where when they click on it, they're able to provide sociodemographic and clinical information on MS, the age when they first experienced the symptom, whether they've had relapses since their last visit, and so forth. There's a quality of life instrument called Quality of Life and Neurologic Disorders. It has 12 domains, and it's administered via a computer adaptive format to minimize the patient burden. I apologize for the sound in the back. The timing of the people doing some yard work is impeccable today. So there's 4 neuroperformance tests. Beginning here at the top right is a processing speed test that captures cognitive performance, contrast sensitivity that measures vision, manual dexterity, which is fine motor skills, and then walking speed. So if we begin here on the top right with the processing speed test, the patient sees a key at the top with 9 different symbols, 9 associated with 9 digits, and then they're shown sets of 15 randomly selected designs here, the images, and then they're supposed to, using the key as quickly as they can, associate the image with the digit, and they do this for 2 minutes. And just to give you a sense for performance on this, it's very unusual for anybody to have over a score of 100, so 100 correct in 2 minutes. In general, it's about 50, and we've shown below 40 is associated with a high likelihood of being unemployed and having other adverse outcomes in MS. The contrast sensitivity test is a test where the patients are shown letters of decreasing size and decreasing contrast to measure their visual acuity. The manual dexterity test, and I'll show this in the next slide more clearly, measures fine motor skills. It's basically a digitized 9-hole peg test where a patient inserts 9 pegs into a grid as quickly as they can with each hand and then removes them. And then the walking speed test, which is a standardized 25-foot walk, how fast the patient can walk in 25, or can walk 25 feet in the clinic, and they do this, it's self-administered. So this is all self-administered. It's all been validated, and the validation study has been published against the standard measures that are used by clinicians, let's say as part of a randomized control study or something. So this is what the manual dexterity test looks like. This black rectangle is the iPad itself, and it sits in a white case, and then the top of the case flips over, and they have 9 metal pegs that they move into the 9 holes, move them out, and then repeat with the other hand. And the score is just simply how fast they're able to do that with both hands. And then this green device here is the timing fob that they use to self-administer the 25-foot walk test. It's basically a timer. So this is what they see on the instructions on how to time themselves over 25 feet. You can see the line here is marked off a 25-foot interval. They start it when they cross, and then they stop it when they finish. And this is an actual test site at one of the participating centers. So each of the patients can self-administer the MSPT in these little booths, so they have some privacy. And then down the center of the room is the 25-foot space where they time themselves on how fast they can walk that length. In terms of the radiologic data, so brain atrophy is a critical marker of MS disease severity and progression, as is the volume of a certain kind of lesion in the brain. And this has been standardized across the network. And this is why there was a requirement for the Siemens 3T. So it's a standardized sequences of images on the same type of scanner. And then importantly, the brain volume and lesion volume is calculated automatically. So this doesn't exist in the real world except for within the MS PATHs network. And so when an MRI is on one of the Siemens 3T scanners is run on the patient, the healthcare provider as well as a radiologist automatically gets brain volume measures and T2 volume measures that they can then use in treatment decisions and so forth, and really help them to understand the disease progression. One thing I didn't note is that a lot of sites have multiple scanners, not all of which are Siemens 3T. And because this is a real world network, we don't require the patients to all get all of their scans only on the Siemens 3T. They schedule according to real world practice. So we get more than half on the Siemens 3T scanners, but it's not on every patient that comes through. And I wanted to note the biologic samples that are captured in MS PATHs. These samples are captured from the patients no more frequently than every 6 months. And the samples are shared between the sites and Biogen. So again, the sites can do whatever they want with the samples according to their own data use sharing committee, what they decide. And Biogen also has independent use of the samples it captures from the whole network. Now, the sites themselves can request samples from across the entire network, but they have free use, of course, of the samples they capture at their own site. So this is just a synopsis of the variables that are captured via MS PATHs. We have talked about the MRI. So the semi-quantitative come from a radiology report that's run on any MRI, whether it's a Siemens 3T scanner or not. And then when it's a standardized protocol, we do get the lesion counts and volumes and so forth that are automatically generated. The biobanking I just mentioned has multiple purposes. For example, we are doing some whole genome sequencing on 8,000 bloods, and we'll have that ready. We're doing that in partnership with another pharmaceutical company, and we'll have that come spring. My Health, this was the first tile that the patient saw on the MSPT, and you can see the demographics and socioeconomic variables that are captured, and then the MS variables that are captured. All of this is self-report. We do capture some data from the EMRs, some important lab data, but also some behavioral data, and then information on medications. This was the neuroperformance measures, the processing speed test, and so forth. And then I didn't give much detail on the NeuroQual. There's 3 major areas: mental, physical, and social, and a total of 12 domains. And as I mentioned, it's administered in a computer adaptive format. So in general, on each of these domains, patients answer an average of 4 before the precision is adequate enough for them to stop. So where are we now? So this learning health system launched in 2016. And by the middle of 2017, all 10 sites were active, and it currently has over 17,000 unique MS patients, over 65,000 administrations of the MSPT itself. And most of the patients, this is probably over 80% now, have longitudinal data. A lot of MRI images have been captured and a lot of bloods as well. This was what I was referring to before, where we're undertaking some whole genome sequencing there. And then of course, there's a lot of EMR data that we've pulled in and integrated across all these other sources. What I'd like to do now, since the focus here is on research quality, real world data, and I know some of the issues I'm going to raise here have been experienced by other investigators in learning health systems. I just wanted to show a few things that I find are interesting and that we need to take into account when we analyze the data. So here's an example of how often patients are coming back. What is the time between visits when they're doing the MSPT? So this is a Kaplan-Meier curve. Of course, if we look at the median time to return, it's roughly 6 months, and this is what the clinicians all predicted it would be. But there's quite a range on this. You can see the rapid increase at this point, meaning a lot of people do come in on a 3-month interval, and then 6 months, and then less frequently right on the 12-month mark. But you see a lot of people are coming in frequently, and then about 1 in 5 over a 3-year period, we don't see return. And what we think is happening there is two things. One is that the sites, these are all large academic sites, they probably are being used as referral centers. So patients come for second opinions, or they come in for infrequent visits, or they may be getting their primary care in a smaller clinic in another state even, but they come occasionally to the site participating in MS paths. And we also think there may be a little bit of the site not always using the MSPT. So even though it's standard of care, sometimes the patients come late to their visits, sometimes when they're starting it, they don't have enough time to complete it, and we get partial answers or something along those lines. So there's a combination of, I think, some lack of use of the instrument, but also this referral center idea. So when looking at this, a question naturally arises is this informative? Do we know something about people that come in more often and those that don't? And so we stratified this by all sorts of patient level characteristics. Here's an example of stratifying that time to return by age, and as expected, younger patients are coming in more frequently. This dotted blue line is the 70-year-old plus patients, and their median time to return is roughly a year, so twice what the youngest patients. And so there's a lot actually that predicts the frequency. Sex doesn't, for example. There's no difference between males and females, but not surprisingly, site is a huge predictor of how often people are coming in. So there is a site that has a very, very consistent 3-month pattern. Within a year, everybody cycles through. So there is some spread, but 80% of the patients are coming in within 3 months. Some sites, they're not coming in even that frequently, less or more than a year apart. This might be just that they're not using the MSPT device as predicted or as they promised early on. But you can see a huge amount of spread here. And so all this information does need to be taken into account when we're analyzing the data, because it's informative. We know that in addition to the site being a predictor of the frequency of assessment, it's also predictive of the outcomes. Even after adjusting for patient characteristics, we see differences. So it's an important feature to keep in mind as we try to make use of the data coming out of this learning health system. See similar things with the MRI. It's about a yearly schedule, and this was expected. We expected it to be more than a year because not all of the assessments. So this is the time between the standardized capture. So not all of the MRIs are being conducted on the Siemens 3T. But there's guidelines that people are supposed to follow with MRIs and treating MS patients, and they vary depending on their risk of adverse events and patient characteristics and so forth, but it's roughly annual. If you look at age, big differences in the frequency of MRIs by age, where the youngest patients absolutely are coming in more frequently for MRIs, and the older patients, not as much at all. And this is also expected from what the neurologists say, because as patients get older and their disease becomes more advanced, the usefulness of an MRI diminishes over time. On the other hand, there's no difference in gender across the patients when it comes to MRI. Again, site is a huge factor. And here's a site that had yet to be contributing its MRIs. But you just see a big spread in how MRIs are used, how often the Siemens 3T are used, and so forth. But if you're going to be analyzing, let's say, brain volume, you need to, again, keep this in mind in delving into the statistical analyses. And my biostatistics team has actually published a couple papers on how to handle this level of heterogeneity in follow-up. And also keep in mind, MRI is on a different schedule than the MSPT itself in most cases. So I wanted to show briefly what these data look like across individual patients. So this is a single patient. Apologize for the axis here, but this begins September 2016 and goes to spring of this year. The red dots in this case represent when the patient completed the MSPT. Blue is they donated blood or gave a sample. And then the golden triangle is the standardized MRI. And a plus just simply means a standard radiology report. So here you have a 6-month, but then over a year, couple of years actually, between successive follow-ups. Here's a patient that came in very frequently. This is unusual for an MS patient, but we see this. The color coding refers to some treatments that I don't need to get into detail now, but just shows that the patient is switching treatments over time as well. But you have some really assessments that are very close in time. But then this patient also, as of the end of summer 2019, hasn't returned in a year and a half when this image was generated. They gave bloods. You have a couple of standardized MRIs several years apart, but these were done on the non-Siemens 3T. Here's one that's very sparse, just 3 assessments over the 5-year period, 1 MRI, no bloods. But this is real world. And the point is just simply to show how heterogeneous things are in a learning health system like this, where the patients are not asked to come back on a set schedule like they are in a clinical trial, for example. Just some other examples. I had one of my staff generate 100 of these just to pass around so people get a sense for what we're actually talking about when somebody says, oh, we'd like to do a comparative effectiveness study. You have to keep in mind, here's a year and a half and then no more. It's how do we make use of these data to generate the insights? The data quality itself is very high, but we have heterogeneity in how the patients come back. But in terms of research quality, this is as of the end of last year. It doesn't take into account this year, but a lot of posters coming out of the network platform presentations. A lot of these are on NFL, which is a blood biomarker for neurodegeneration. It's really important in neurologic diseases at this point. A lot of manuscripts published. We've had about 40 more presentations, and I think between 5 and 10 more manuscripts submitted so far. So it is productive. The sites are generating a lot of evidence from it and using it to advance research as well as treat their own patients. And I know we're kind of running out of time. So
yeah, Carl. Yeah, please wrap up quickly.
Yeah, sure. Okay, so just the learning. I kind of talked about these the benefits of the system, and then some of the learnings that we've made from it. And I'm happy to share these slides, but I can end it there. Just basically the real world data in this learning health system we think is very high quality, but there's just some standard issues that occur in the context of real world data that do need to be taken into account for evidence generation purposes. I can end it there, AJ.
Okay, all right, thanks. Carl, great presentation. I hope you can ask maybe answer questions about those information you haven't shown in your slides. Even though we are almost close to the end of the hour, I think I will probably extend this meeting for maybe 10 minutes. If you have other schedule, and you can leave, but if you prefer to learn more about from Yuri and Carl, and we will have probably 10 minutes for discussion, for question and discussion. And there are several questions already in the chat. So let me start from the beginning and of the question list. I think Yuri has a question already. Could you, Yuri, could you just repeat those question and answer that you gave to the group so that everyone learn from it?
So I think one of them, comment question from Dr. Ed Hammond about the analysis to identify the best of the best. And I think one of the challenges all these networks will have is how do we synthesize the learnings and share that with other groups. I think the sustainability will be whether people find value, and while there can be a lot of knowledge generated, if that's not easily retrievable, I think then it'll be hard to sort of maintain. So I think that's it. How you synthesize that knowledge will be specific to each one, but I think that needs to be part of the operational plan. And then the other comment related to an earlier question or comment about registries, whether they'll be obsolete. And I think if they can be integrated with communities that can act on it, I think the registries will have much more value than something that's developed and then you hope people come later. But if they're developed within a community, I think it'll be, the design of that registry will be better. And then there'll actually be more people that will actually use it. And I think the presentation we just heard sort of an example of something that had good broad input, and I think it's has high value.
Great. Yeah, I want to add the question on top of that to Yuri. Since you have the network and it's very good to know that you actually standardize the data to some extent, then you are actually at a position that you could do analytics and even machine learning. Do you have a plan, or have you done anything with machine learning yet so far on your network?
So we're starting to do machine learning, trying to match patients to clinical trials and match them to specific aspects of clinical practice guidelines. And that requires not only standardizing the representation of the clinical data, but as you know, most clinical practice guidelines are text. They're not really structures. A few formal structures have been proposed over the years, but I don't think has been widely adopted in terms of structure and sharing that. And then virtual tumor boards happen all the time in America, but there are very few times that they're actually summarized or recorded. And so I think, there are some standards like OMOP and connectivity standards like HL7, but I think each community has to agree on which classification terminologies and data models that they want to use. Most have already their existing data models, but so then you'd have to figure out how to transform that data for that. I think COVID's a really good example of where it would have been great if we would have done that before COVID.
That's right.
But there are 2 or 3 consortiums, one out of Hopkins, one out of here in the Harvard area hospitals. There's one on the West Coast as well. And I think there's a grant that's going to be funded shortly in the United States for tracking long-term COVID. The challenge will be to get people to agree on the common data model for these studies. But if you don't have that, then your AI algorithms will be tailored and optimized to your local, and you won't have the benefit of scaling across institutions.
Yeah, that's right. Yeah, that's I think a big challenge in terms of really take advantage of the network. So standardization of the data, is a key, and interoperability has to be there in order for us to actually really move up one step to the so-called AI world, right? But we're going to discuss a lot of those topics and challenges in our future forums. Now, let me go through the next question for Carl. I think this question as do the people involved in MS PAS see themselves as patient receiving care or as subject participating in research? This is a question from John Burke.
Yeah.
Yeah, Carl, could you answer that?
Yeah,
you can also see the question in the chat.
Right. Yeah, no, that's a great question. My impression is that they see themselves less as research subjects because as they're completing the MSPT and so forth, it's their neurologist who is looking at the outcomes and needs to see that. So I know they're probably continue to be cognizant of the fact that their data are being shared, but it's not like when they complete an assessment that it's a reminder that this is a study-specific assessment. It's actually for their standard of care, and they've decided to share those data. And then there's the follow-up about stopping at 5 years, where it is at 5 years, and the practical reality is we need to have discussions about reissuing it every 3 years, and we're in the process now. And our hope, of course, is that the sites want to continue, because one slide I didn't show is that it really does take a long time to generate good longitudinal data over time, right? Because a patient needs to switch treatment, so we have their baseline, and then they need to be followed for several years because it's a slow progressing disease. So, you know, the real benefit of this learning health system in terms of generating real world data is to keep it going for a long time.
I have one comment here.
Yes, go ahead, Jin.
This is my first time. Thanks for AJ's invitation, and I thank the two speakers about this grateful presentation about this LHS. We are actually, in my view, you are doing the infrastructure development. It's a large scale, systematic scale, and what we are doing here is for users, patients, and we think it's crucial to include the user in the loop, right? When we make a decision for their care support. And we have a collaboration here, and revolving the digital twin for cancer patients. This idea has been founded recently by NCI and DOE. Now we are expanding to more collaboration work. And digital twin is like granular level, user level, right? And those HLS and digital twin should be worked together and will be more powerful.
Yeah, connecting the digital twin concept or practice to the clinical research network, that would be great. I would like to see that. So there's one more question for Carl. How might patient follow-up reliability be improved with the technical solution?
Yeah, so also a great question. So when MS-PAS was originally set up, the idea was to be as hands-off as possible so that other than the fact that the site had changed its standard of care, which is a huge change, that Biogen was not involved in the day-to-day. So in contrast to a study, let's say, where you query the data and ask for confirmation of values, that's not done, or things like following patients up. If the site wants to do that, that's, of course, we support that, but it's not something that Biogen is imposing or asking of the sites. Though in the next iteration, that may be a wise thing. I think your point is well taken, but this was like a demonstration project of, can you change standard of care, use some very sophisticated standardized quantitative measures, and just let it run and see what quality of data. So there's in some of the lessons learned, I would have gone into some of that now that we're setting up another one and another indication, we're taking those lessons and we're applying it to the next LHS.
All right, thanks, Carl. Anybody else has question? There's some request about the slides, so I will in touch with Carl and
Sure.
Yuri to see whether you can share the slides, and I can then post in our LinkedIn group.
Absolutely.
And I also want to encourage people to join the LinkedIn group so that you can get the notice as well as the slides.
I'll put them on the, as soon as we are allowed to post them, I'll put them on the website, and I'll put links in the chat right now to those things.
Okay. If I do I miss any questions from anybody in the audience? You can speak up if you have questions that I miss. Alrighty, then let me share my, I don't need to share the screen again, but thanks again for Yuri and Carl, and also thank our organizing committee for put up this event. And for the next forum, we're thinking that have the next forum in probably early next year. We probably will talk about more about this research network, because since there's a lot of things going on in this space, and that's a very nice place where you can apply the learning health system concept as well as connect this to the traditional healthcare hospital focus care delivery. So hope everyone will join us next time. Bye bye. Thank you very much.
All right. Bye bye.
Thank you.
Bye bye.